Let's start with diabetes mellitus in children from Nelson's, page number 3515, chapter 629, edition 22. Diabetes mellitus. Starting with the classification of diabetes mellitus. Diabetes mellitus is a common chronic metabolic disease characterized by hyperglycemia as a cardinal biochemical feature. We all know that there is hyperglycemia. The major forms of the diabetes are differentiated by the insulin deficiency versus insulin resistance, right? So in type 1 diabetes there is deficiency, in type 2 there is resistance. So type 1 diabetes mellitus results from the deficiency of insulin secretion because of the pancreatic beta cell damage, and type 2 diabetes mellitus is a consequence of insulin resistance, occurring at the level of the skeletal muscle, liver and adipose tissue with various degrees of beta cell impairment. Type 1 diabetes mellitus is the most common endocrine metabolic disorder of the childhood and adolescence with important consequence for the physical and emotional development. Individuals with the type 1 DM confronts serious lifestyle alteration, including an absolute daily requirement for exogenous insulin, the need to monitor their own blood glucose, and the need to pay attention to the dietary intake. Morbidity and mortality stem from a constant potential for acute metabolic derangements and from long-term complication. Potential acute complications include the development of hypoglycemia related to insulin excess, or hypoglycemia can occur due to insulin excess or hyperglycemia, ketoacidosis from insulin deficiency. Long term, these were the acute complication. Now the long term complication manifest in the adulthood and are related to adverse effects of chronic hyperglycemia and associated metabolic abnormalities on the tissue and the organ system. And long term complications that are happening is because of adverse effects of chronic hyperglycemia and associated metabolic abnormalities. Okay, this can result in the microvascular disease such as retinopathy can occur, nephropathy and neuropathy, and macrovascular complications such as ischemic heart disease and arterial obstruction with the gangrene of extremities. These were what? Micro and macrovascular complication. What were the microvascular complication? They were retinopathy, nephropathy, neuropathy, right? And macrovascular complications were ischemic heart disease, arterial obstruction with gangrene of the extremities. Things like these can happen in long-term complication. Diabetes mellitus is not a single entity but rather a heterogeneous group of disorders in which there are distinct genetic patterns and other etiologic and pathologic mechanisms that lead to impairment of the glucose. Glucose tolerance through deficient insulin production or action. The American Diabetes Association has proposed a diabetes classification system that includes 4 categories: type 1 diabetes, type 2 diabetes, and other specific types, and gestational diabetes. This classification is proposed by American Diabetes Association, ADA. What is the classification? Type 1, type 2, other specific diabetes, and gestational. An expanded list of the diabetes etiology is provided in this table, which we will read. The current criteria for the diagnosis of diabetes are provided in another table. Through a thorough clinical history and physical examination are often sufficient to determine the etiology. However, in some cases, additional testing may be required. Starting with type 1 diabetes mellitus, formerly called as the insulin-dependent diabetes mellitus or the juvenile diabetes. This was previously its name, insulin dependent diabetes mellitus. Now it's type 1 diabetes mellitus. It is characterized by low or absent levels of endogenous produced insulin and by dependence of exogenous insulin to prevent the development of diabetic ketoacidosis. So basically in type 1 DM there is absent endogenous insulin. That's it. And they are dependent on the exogenous insulin to prevent any ketoacidosis. And ketoacidosis is an acute life-threatening complication of the type 1 DM. The natural history includes 4 distinct stages. Preclinical, what are the 4 stages? Preclinical beta cell autoimmunity with the progressive defect of the insulin secretion, onset of clinical diabetes, transient remission of the honeymoon period, and established diabetes during which they may occur acute or chronic complication and decrease life expectancy. The onset occurs predominantly in the childhood with a median age of 7 to 15 years. This is the age of onset, but it may present at any age. The incidence of the type 1 DM varies markedly across the world but has increased in nearly all parts of the world over the recent decades. Okay, and both the genetic susceptibility and the environmental factors contribute to the pathogenesis. Susceptibility to type 1 diabetes mellitus is genetically controlled by alleles of major histocompatibility complex class 2 genes. Susceptibility, how much is a person susceptible of getting a type 1 DM is controlled by what? There's no in between. Alleles of the major histocompatibility complex class 2 genes expressing the human leukocyte antigens. Okay, so they are controlled by the major histocompatibility complex expressing the human leukocyte antigens. Autoantibodies to the beta cell antigens, including the islet cell cytoplasm, insulin antibody, and glutamic acid decarboxylase, GAD. This is the full form of GAD, that is glutamic acid decarboxylase. Islet antigen 2, you have to remember the full form of GAD, right? Glutamic acid decarboxylase and zinc transporter 8 also are detected in the serum from the affected subjects. So these are the antibodies which can be detected. Okay, let's read the antibodies again. Autoantibodies to beta cell antigens, including the islet cell cytoplasm, insulin antibody, insulin autoantibody, IAA. Insulin autoantibody is the IAA, GAD, which read was glutamic acid decarboxylase. Islet antigen 2, IA2A, formerly known as the ICA512, and zinc transporter 8, ZNT8A. These can be detected months to years before the clinical onset of type 1 diabetes mellitus. In some children and adolescents with the apparent type 1 DM, the beta cell destruction is not immune mediated. This subtype of the diabetes occurs in patients of Africa or Asian origin and is distinct from the known cause of beta cell destruction, such as drugs or chemicals or viruses, mitochondrial gene defect, pancreatectomy, and ionizing radiation. These individuals may have ketoacidosis, but they have extensive periods of remission with the variable insulin deficiency. Similar to patients with the type 2 diabetes mellitus, patients with type 1 diabetes mellitus require lifelong treatment with insulin. Okay, let's move ahead about type 2 diabetes mellitus. We will read in detail about it in the further parts of this video. Type 2 diabetes mellitus, formerly known as the adult onset diabetes mellitus or non-insulin dependent diabetes mellitus. Okay, this was adult onset, formerly known as, and non-insulin dependent. Develops because of insulin resistance and progressive non-autoimmune beta cell failure. There is no autoimmune system involved in this type 2 diabetes mellitus. There is beta cell failure, but that is totally different, not related to any autoimmunity. There is strong heritable component of type 2 diabetes mellitus. Although the genetic basis remains poorly understood, population-based studies have linked the type 2 diabetes mellitus risk with polymorphism in a large number of genes related to the insulin secretion, insulin action, energy expenditure, and birth weight. However, the collective contribution of these variants to overall type 2 DM risk remains low at less than 20%. Although type 2 diabetes mellitus has long been the most prevalent form of diabetes in adults, the rise in childhood obesity over the past few decades have led to markedly increased incidence of this disease in children and adolescents. Okay, what we read here was type 2 was mainly in adults, but due to rise in childhood obesity over the past few decades has led to markedly increase in the incidence of this disease in children and adolescents also. Okay, so it's important in obese children, to diagnose type 1 DM, we have to do that antibody test. Okay, pediatric type 2 diabetes mellitus accounts for most of the new cases of diabetes in high risk populations, such as obese adolescents of black or Hispanic ancestry. Okay, So pediatric type 2, we will diagnose type 2 diabetes mellitus will diagnose in obese adolescents. Will maybe diagnosed. Okay, childhood onset type 2 diabetes mellitus differs from adult disease, and that is associated with more rapid decline in the beta cell function and earlier development of type 2 diabetes mellitus related complication. So how is the childhood one childhood type 2 is different from the adult, that it is associated with more rapid decline in the beta cell function and earlier development of type 2 diabetes mellitus related complication. This was important, okay. We have to keep this in mind, that type 2 diabetes mellitus is more dangerous in childhood. The presentation of type 2 diabetes mellitus is typically more insidious, okay, than that with the type 1 diabetes mellitus. In contrast to patients with the type 1 diabetes mellitus who are usually ill at the time of diagnosis and whose presentation rarely spans more than a few weeks. Right. The presentation of type 2 diabetes mellitus is typically more insidious. We know that. It will occur slowly, not as rapid as type 1 DM. Then with the type 1 DM, in contrast to patients with the type 1 DM who are usually ill at the time of diagnosis and whose presentation rarely spans more than a few weeks, children with the type 2 DM often seek medical care because of excessive weight gain and fatigue as a result of insulin resistance or incidental finding of glycosuria during the routine physical examination. So what we read here is, like the type 1 DM patients, they will be ill at the time of diagnosis, and their presentation, after the diagnosis, their presentation won't be more than a few weeks. But type 2 diabetes mellitus patient they will present with excessive weight gain and fatigue as a result of insulin resistance or incidental finding of glycosuria. A history of polyuria, polydipsia is not always a cardinal feature in these patients. Acanthosis nigricans, that is dark pigmentation of the skin creases in the nape of neck, especially a sign of insulin resistance, is present in majority of the type 2 DM patients. Acanthosis nigricans, okay. And this acanthosis nigricans is accompanied by a relative hyperinsulinemia at the time of diagnosis, okay. However, as the disease progresses, beta cell function becomes increasingly impaired such that children with advanced type 2 diabetes mellitus often present in the diabetic ketoacidosis, okay. Type 2 DM also can present with diabetic ketoacidosis. Healthy lifestyle intervention and treatment with the metformin remain the cornerstone of type 2 DM diabetes mellitus treatment in children and adolescents. So in children with type 2 DM, we have to give what? Metformin, okay. And healthy lifestyle intervention and treatment with the metformin, this is the cornerstone of type 2 DM diabetes mellitus treatment in children and adolescents. Liraglutide is approved in children more than 10 years and may have additional benefits of slowing weight gain. What other drug can be used is liraglutide, okay. It is a glucagon-like peptide receptor antagonist, GLP receptor agonist, liraglutide is approved in children more than 10 years only. After 10 years we can give, and it has what additional benefit? It has additional benefit of slowing weight gain. Insulin therapy is required for patient who presents with severe hyperglycemia and for those in whom the hyperglycemia worsens in spite of lifestyle modification and non-insulin pharmacological management. Fine. Starting with other specific types of diabetes, first we are going to read about is the monogenic diabetes. The term monogenic diabetes is used to refer to a the term monogenic diabetes is used to refer to a heterogeneous group of single gene disorder resulting in impaired insulin secretion. What is happening here is heterogeneous group of single gene disorder which resulting in impaired insulin secretion. There is impaired insulin secretion, okay. This category encompasses what? MODY, that is maturity onset diabetes of the young, and transient and permanent neonatal diabetes. They are the types of monogenic diabetes. Characteristic of the monogenic diabetes can include age of onset before 6 months in transient and permanent neonatal diabetes, development of hyperglycemia before 25 years of age, and a strong family history of diabetes. Fine, these are the characteristics of monogenic diabetes. Monogenic etiologies are estimated to comprise anywhere from 1 to 10% of all the diabetes cases, with uncertainty related to the clinical difficulty in differentiating these cases from type 1 DM and type 2 DM. Monogenic form of diabetes may present with hyperglycemia, consequent polyuria, polydipsia, or may be diagnosed simply by routine screening also. Extrapancreatic manifestations vary by genetic defect and can include hepatic, renal, and central nervous system manifestations also. There can be extrapancreatic manifestations of this monogenic one and can include hepatic, renal, and CNS manifestations also. Treatment is guided by the genetic diagnosis and clinical course, with some forms of being responsive to oral sulfonylureas and others requiring insulin replacement. Children diagnosed with the diabetes before 6 months of age should have genetic testing for TND and PND. An older individual with diabetes not characteristic of type 1 DM or type 2 DM in the setting of a family history of diabetes should have genetic testing for monogenic forms of diabetes. This table we have etiologic classification of diabetes. Let's read about this. Starting with type 1 diabetes, in which there is beta cell destruction, ultimately leading to complete insulin deficiency. It is immune mediated also, and it can be idiopathic also. And type 2 diabetes, there is variable combination of insulin resistance and insulin deficiency. Okay. In type 2, there is insulin resistance, but there is variable combination of insulin deficiency also. It is atypical and typical. Other specific types we have genetic defects of the beta cell function. There is monogenic diabetes, which include the neonatal diabetes, pathogenic variants leading to transient neonatal diabetes, and pathogenic variants leading to permanent neonatal diabetes also. These were monogenic diabetes. Other was MODY, maturity onset diabetes of young. There are various chromosomes for MODY also. So we read about MODY and these are all under the genetic defects of beta cell function. Then there is something called as the mitochondrial DNA pathogenic variant, include one form of Wolfram syndrome, Pearson syndrome, Kearns-Sayre syndrome, and maternally inherited diabetes and deafness. Wolfram syndrome, that is D mode, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, DID mode. Diabetes insipidus, diabetes mellitus, and optic atrophy and deafness. Okay, starting with the WFS1, this is under Wolfram syndrome. Wolframin chromosome 4p, Wolfram locus 2 chromosome this, and Wolfram mitochondrial. Thiamine responsive megaloblastic anemia and diabetes. Now second group, genetic defect of insulin action. These were all genetic defect of beta cell function. Now insulin action. Type 1, type A, insulin resistance, Don-Huey syndrome, Rabson-Mendel syndrome, lipoatrophic diabetes syndrome. Other genetic syndrome associated with the diabetes, insulin resistance or deficiency are Down syndrome, Turner syndrome, Klinefelter syndrome, Prader-Willi syndrome, Bardet-Biedl syndrome, Elstrom syndrome, Werner syndrome, and Friedreich's ataxia. These are other genetic syndromes which are associated with the diabetes.